Welcome everyone. My name is Anthony Kobe. I'm the Director of Collaboratives and Community Engagement at the Lynn Institute. In the Lynn Institute, we're a nonprofit organization here in Oklahoma City, and we focus on working with vulnerable populations and trying to increase access to resources and opportunities in the community. And this Foundations of Wellness program is something that we've been doing for some time now, and it's really just all geared at getting folks access to information related to their health and getting healthy. And we've been looking at recognizing the awareness in each month, the National Awareness Calendar. And so this month, Lynn, as an organization, has been trying to put a focus on vision care. And so I'm very excited to have the two folks we have on today to talk about vision care and the importance of vision care and things related to vision care. And so I'm super excited to introduce Dr. Griffin from the Oklahoma Eye Institute and Dr. Bonner from Adventure Vision. Thank you guys both for being on with us today.
Sure, thank you.
So I'm excited because we were just recently able to do free vision screenings for the community last week. And as someone who isn't, well versed in vision care or the things related to some of the issues related to vision care, there was a really big turnout, and folks were really interested and excited to figure out, how things were looking, no pun intended, for their vision care. And so I'm excited. We are so pleased to have you. And so I'd like to throw it to I know both of you have some slides to show us. I'd love to throw it to one of you to kind of kick things off.
Okay, I'll go ahead and get started. I'll share my screen. All right. All right, can everybody see that?
Mm-hmm.
All right, so my name is Dr. Nigenda Griffin. Just a little bit about myself. I'm an island girl. I was born and raised in the Caribbean, and now live in Oklahoma. I live in the Oklahoma City area, but I work in Lawton, Oklahoma at the Oklahoma Eye Institute, like Anthony mentioned. I went to the University of Southern California for undergrad, so I am a Trojan, Phi Trojan, and then I went to NSU OCO here in Oklahoma for optometry school, okay? So the objectives of today's presentation, I'm going to talk about the importance of comprehensive eye exams, and then I'll talk about some common ocular diseases, specifically glaucoma, diabetic retinopathy, and cataracts. And then in the end, after Dr. Bonner speaks, then we'll open up the floor to any comments or questions. All right, so let's jump right into it. And let's talk about the importance of a comprehensive eye exam. So these are questions I get a lot of times from patients or friends, is what exactly is a comprehensive eye exam? And I think for most people, when you think of going to the eye doctor, you think of glasses and contacts, and that's fine. That's what will drive most patients into the eye doctor, but that's what we consider the refraction. That's just part of the eye exam itself. The next part is the eye health check. And this is really important. And during this part, you should be dilated, and the eye doctor may choose to do a fundus photo or not, but you definitely should be dilated. And this allows us to see the back of the eye and examine the entire retina, the entire eye health. So I have an image here, and on one side, you can see a picture of the pupil that's undilated as opposed to a dilated pupil, where we could get to see everything that's happening inside the eye. And another thing I wanted to mention, because a lot of patients may not know this, but the eye health exam is a medical exam, okay? So other patients will not come in because kind of like dental plans, they'll say, oh, I don't have a vision plan. I just have medical insurance, whether it's Blue Cross Blue Shield, Medicare, so forth. So they'll avoid the eye doctor. However, it is medical, which means if you have Blue Cross Blue Shield, Aetna, United Health, it should be covered, okay? So just like how you go to your PCP or dentist every year or twice a year, you should kind of think about going to your eye doctor in rotation as well. How often should you have an eye exam? At least once a year, okay? So some patients may need more depending on the diagnosis. The doctor may have you back in 3 or 6 months, but you definitely should be dilated at least once a year. And this is the most common thing people say is, oh, I see fine. I don't need to go to the eye doctor. I have good vision. And yes, you can have good vision, but that doesn't mean you have a healthy eye, okay? That's just one aspect. So but if you go to the eye doctor and we catch some of these diseases early on, like glaucoma and macular degeneration, it's much easier to treat them in the early stages as opposed to if you wasn't going to the eye doctor because you have good vision, and then we start treating it way in the later stages. So let's look at some of these ocular diseases. So let's start with glaucoma. This is a common one. I think a lot of people are familiar with the term glaucoma, but may not know exactly what glaucoma is. And you see I have written here the silent thief of vision, or some people call it the silent killer of vision. And that's because in the very early stages of glaucoma, it doesn't present with any symptoms, meaning there's no pain receptors in the back of the eye, okay? So this is not something that somebody can feel in the very early stages, or even in the late stages, you may not feel it. That's where you'll experience vision loss. But there's no symptoms at all to indicate that we have all these signs of glaucoma. There are signs that we can see when you come in for the eye exam, but a patient will not know just without an eye exam that they may have the early stages of glaucoma. So glaucoma in itself, and you see I have here, is a condition that causes damage or harm to the optic nerve. And I have a picture here, and this is the optic nerve that you can see connects the eye to the brain. So when you think of the optic nerve, I want you to think of like having a TV and the power cord. And you can have a perfectly fine looking TV, but if it's not connected to the power source, or you have a damaged cord, then the TV cannot function, correct? Same thing with the optic nerve. You can have a completely healthy looking eye from the front, the cornea, tear film, and so forth. But if that optic nerve is damaged, which means the signal from the eye to the brain is not being relayed very good, therefore this will eventually affect the vision. If left untreated, it can be very dangerous. This is a very treatable disease. If we catch it early, most people should not lose vision from glaucoma if we're able to catch it and start treating in the early phases. And next thing that's connected with glaucoma, when you go see your eye doctor, you may hear us mention the term your eye pressure or intraocular pressure. This is different from the blood pressure that you have. This is a number that you may hear 21, 22. You'll get a different reading for each eye. And normal intraocular pressure is 10 to 21. So that's ideally where you would like your eye pressure to fall. If you have a pressure that's higher than 21, for us, again, this could indicate that we may start to see some damage happening to the optic nerve. So how is glaucoma in itself diagnosed? One, first thing we'll do is dilate the eyes and we actually get a view of the optic nerve itself, so we could see damage. If we do see damage happening at the back of the eye, then the doctor may order additional tests, an OCT, a visual field. These are all things that will help us come up with that diagnosis of glaucoma. So let's take a look at what we actually see when we dilate the eyes. So here we have some pictures of, we have two optic nerves. So if we dilate your eyes, this is what we would see in the back of your eye. And you can see on the left side, this is a normal healthy optic nerve here. And you have an opening in the middle that we call the cup. And this is what we look at for glaucoma. This opening, as you can see, should be about 1/3 the size of the entire disc itself. On the right side, on the other hand, you see the opening here is much, much wider. And we have what we call cupping. And this is a sign indicating that we have some glaucoma changes. And this would be actually a very severe case of glaucoma that we're looking at on the right side. If you've ever been diagnosed with glaucoma or been to the eye doctor with a family member or friend who had glaucoma, you may hear them discuss it in terms of using the donut metaphor, where we say if you have a donut, you have that hole in the middle of the donut, it should be about 1/3 the size. If you started eating from the middle of the donut, then you have less donut, correct? So that's kind of what's happening with glaucoma, is we see damage happening where that opening in the middle of the nerve is just becoming larger, and therefore you have less healthy tissue. All right, so let's look at higher risk factors and treatments for glaucoma itself. So one of what I mentioned earlier, intraocular pressure should be between 10 and 21. So if you go to the eye doctor and the pressure for some reason is elevated. Now let's keep in mind though that we have to mention that you can have what we call normal tension glaucoma. And this is a patient whose pressure is not high. However, we still see damage happening to the optic nerve, okay? And as I know I said before, but I'll say it again, there are no pain receptors. So this is not something that you will be aware is happening. You're not going to wake up in the morning with pain and discomfort with the eye, and that's glaucoma. That's something else that's happening with the eye, okay? Being over age 60, so this is typically a disease of the older population, although we do have patients who are pediatric who also have some congenital glaucoma that Dr. Bonner might touch on a little bit more. And we also have patients, sometimes we have I have one who I'm treating right now. She's in her 40s and she has a very progressive, severe case of glaucoma. But typically we see this in our older patients because this disease takes a long time to progress. So if we catch it early, this isn't something you wake up with the next day and suddenly have vision loss. It takes years and years for glaucoma to progress. However, it is an insidious disease, okay? It's sneaky, it's harmful, and it's just slowly causing damage to the eye. There is a correlation with race as well, and we see Black, Asians, and Hispanic. We see a higher rate of glaucoma among these patients as well, especially among African Americans. If you have a family history of glaucoma, and by family history, referring specifically to mom, dad, brother, sister, not so much great grandparents down the line, but a close immediate family, if there's any glaucoma among them, then you're at a higher risk. Certain medical conditions, diabetes, high blood pressure, sickle cell anemia, basically microvascular diseases that could decrease blood flow to the optic nerve itself can also put you at higher risk for glaucoma. And then finally, myopia or nearsighted patients. So nearsighted, these are the ones who have trouble in distance vision, but might have good near vision. You're nearsighted or myopic. You tend to have a larger eyeball, which stretches the retina, which makes those retinal cells a little bit weaker and therefore more prone to damage, hence, which could lead to glaucoma as well. So how do we treat it? Early diagnosis is key. Like, that's the best thing. If we catch it early, then we could monitor this glaucoma, possibly just put you on drops that you use at bedtime to keep that eye pressure down and prevent progression. We cannot bring back any tissue that's already lost, but what we can do is stabilize the tissue that you have left. Another thing we could do is a SLT. This is a laser procedure that we do in office. I do these all the time on patients. If we do a SLT, you may not be on any drops at all, and white does the same thing. It helps to lower the eye pressure as well. In severe cases of glaucoma, sometimes we do have to send you to a glaucoma specialist, and we have to do surgery or implants at that point to try and stabilize your glaucoma, okay? MIGS, these are procedures that can be performed, some of these can be performed during cataract surgery, which I'll discuss later on. But if you have cataracts, and again, because glaucoma is generally a disease of the older population, more are geriatrics, most of them will have, well, all will have cataracts at that point. And if you have your cataracts removed, we can do a 2-in-1 procedure where we treat the glaucoma as well. So I wanted to look here at what vision is like for a patient who has glaucoma. So on the left side, we see what a healthy eye looks like. But on the right side, this is how glaucoma will affect your vision. It doesn't start centrally, okay? It starts in your peripheral vision. So we'll start in, and then most patients will not notice the glaucoma changes until the vision, your functional vision is affected. And you see what's happening here. You're basically left with a small tunnel vision. You'll never go completely blind from glaucoma, but it does leave you in the very last stages with a very tiny island of central vision. It's the second leading cause of blindness in the US. We shouldn't have a lot of patients losing vision again from glaucoma, not with the technology and resources that we have now. We have the ability to detect glaucoma in the early stages and start treating it and preventing it from progressing. So according to the CDC, the #1 cause of vision loss in America in adults is diabetic retinopathy, okay? And I think this lady is from Oklahoma. You could correct me if I'm wrong, but I like this meme. It says, I got diabetes, ain't nobody got time for that. And I feel like that's what happens a lot of times with my glaucoma patients, my diabetic patients. If they've had diabetes for a long time, they feel like they're doing fine, and therefore they just kind of stop paying attention to monitoring the blood sugar, blood pressure, the A1C, it just kind of falls as no longer a priority for them. But it is the #1 cause of blindness, so it should be something that should be kind of on the forefront of the health, taking care of the health. The other thing too is a lot of diabetic patients I meet have never been dilated, and every diabetic patient needs to be dilated at least once a year, okay? This is a must. Diabetic changes, if we catch it in the early stages, it's so much easier to treat than in the late stages of diabetic retinopathy. So let's look here again. I have two images. And again, if we dilate your eyes or take fundus photos, this is two images. This is what we might see. So on the left side, we have a normal, healthy retina. And on the right side, you can clearly see this is not a healthy retina. So these are some diabetic changes. We see lots of hemorrhages, hemes. We have what we call exudates. Oh, sorry. We have some swelling that's happening around the central vision. I mean, so this is a really, really sick, unhealthy eye. But before we start to see these type of changes, a lot of times it starts out as minor changes in the retina. And this ideally would be the stage that we would like to catch it, because we could always monitor it, treat it, have the conversation with the patient, contact the primary care physician, and kind of come up with a really good co-management plan with how we plan to help this patient kind of get their blood sugar, A1C, everything under control, and ideally help resolve some of these retinal issues that's happening. A lot of patients I talk to, I've heard people say, oh, you know, well, I have diabetes, so I'll lose my vision anyways. What's the big deal? That's also not necessarily true. Although there is a correlation between the longer time you have diabetes, yes, there's an increase in the chance of developing some level of diabetic retinopathy. It doesn't mean that diabetic retinopathy will be severe, meaning we could catch it in the very early stages, meaning mild, as opposed to catching it in the very late stages when it's sight threatening. So again, let's look at risk factors for developing diabetic retinopathy. And I kind of mentioned this before. One is the longer you have diabetes, there is just a correlation. And part of that, again, has to do with the patient also just not taking care of the health as much. It's just no longer a priority for the patient. Poor control of your blood sugar levels, high blood pressure, high cholesterol, basically any vascular disease as well, pregnancy, smoking, and of course, there's a correlation with race again, where we see a higher rate in African American, Hispanics, and Native Americans. So just to kind of share with everybody, just to go over these numbers quick, your cholesterol, your total cholesterol, you would like to be below 200. For your blood sugar, if you are diabetic, ideally that A1C should be below 7. Please pay attention to that A1C number. Every time patients come in, we always ask them, what was your most recent A1C? And patients oftentimes have no idea what we're referring to, or they've heard it, but just didn't really pay attention to it, okay? So this should be, I think every 3 months, some PCPs will retest your A1C. We see here your fasting blood glucose should be between 80 to 130, and 2 hours after a meal, less than 180. Blood pressure, we should be below 120 over 80. These are things that you should be monitoring at least, if not daily, at least a few times a week, to just make sure that everything's under control. So again, let's look at the symptoms and treatment for diabetic retinopathy. And again, I have some images here. On the left side, you see a normal vision. On the right side, this is what a patient with diabetic retinopathy vision might look like. So very different from glaucoma that started on the periphery and slowly walks way in. With diabetes, if you develop hemorrhages or anything, you'll have floaters, which could be, if you have a detachment, you could have blood floating around the vitreous, and it could eventually lead to a detachment. So this is kind of what a vision might look like. On the very bottom, I have some scans. This is called an OCT scan. So this is if you came in, we will do a scan of the back of the eye. On the left side, it's a normal retina. You see here, nice, smooth lines. This dip is normal. This is where your central vision is located. And on the left side, on the right side, sorry, you can see there's lots of swelling, a detached retina. Again, this is a really bad case that would probably send off to a retina specialist. So common symptoms, blurry and fluctuating vision, which is one of the things that will drive a patient into the eye doctor a lot of times. Patient will say, hey, I got glasses last week. They walk fine, and all of a sudden I can't see them anymore. I can't see out of these glasses anymore. And our blood sugar is fluctuating, and so is the vision. Everything's just changing and constantly fluctuating. Floaters or cortinol veil over the vision. It's normal to have a few floaters in your vision. Meaning I have some, most people have some floaters. You see them sometimes if you look at certain background. It's not common to have hundreds and thousands of floaters in your vision, okay? Raindrops is what patients will describe it as. If you ever see that as something you want to come in for. And then of course, partial or complete loss of vision will definitely bring a patient in to the eye doc. So treatment in the early stages, meaning you come in and it's just mild, moderate, we probably will just monitor, see you back every 3 to 6 months and just dilate your eyes, make sure everything's resolving. In the more severe cases, for instance, like this case here, this patient will be sent to a retina specialist where they'll treat you with either a laser treatment. If there's any detachment, they'll use a laser to reattach the retina, or we may have to do injections into the eye, anti-VEGF, to basically prevent the bleeding from happening. All right, so let's look at the next one, which is cataracts. And again, this is one that will affect primarily the older population. Again, we do have some kids that have cataracts. And again, I'll leave that to Dr. Bonner because that's more his area of expertise. So who gets cataracts? And the answer is everyone. Everybody gets cataracts, okay? If you live long enough, you'll get wrinkles, you'll get gray hair, and you'll get cataracts. It's just part of life, okay? So patients come in and they hear about, oh my God, I have cataracts, and they feel like it's the worst diagnosis. It's not. Everybody gets them. You guarantee to get them. You guarantee to need cataract surgery at some point in life, okay? And so this is one of the most commonly performed procedures. We do about 2 million cataract surgeries a year. At the practice I work at, we do cataract surgery 4 days a week. We do them a day apart, meaning you do your right eye on a Wednesday, we do your left eye on a Thursday. There's not a lot of downtime from cataract surgery. But I just want everybody to know that if you ever go in and get this diagnosis, this is not a why did this happen to me? This is just part of living that we all will get them at some point, okay? So let's look again. And the reason why I wanted to share this picture here, I'm not going to talk about ARCAS today, but I just wanted to show it because I get this a lot actually. I'll tell patients, okay, so you do have cataracts, and they go, oh yeah, I know I have cataracts. I see this little gray area. We see it all the time. This is actually not the cataract, okay? This is a different diagnosis known as ARCAS, and it indicates that you have basically cholesterol. This is a result of high cholesterol that's happening. It's a benign finding, nothing that we need to treat or anything. It's just something that we see. Usually more apparent when you have darker irises, so darker colored eyes. You tend to see this change a little bit more, but this is not the cataract. The cataract is behind the colored part of the eye, in the middle of the eye, in an area known as the lens. Okay, so here we have a normal eye here, and you see inside the pupil where it's dark, and here you have the cataracts where it's just cloudy and dense and opacified. So let's look at it from a different view. And again, here you have a normal eye on the left side, and you see light is coming in, it's going through a crystal clear lens and hitting the retina in the back. And therefore you have a clear image going in and coming out. Here on the right side is what cataract looks like. It's in the middle of the eye. You see that lens is cloudy, it's opacified. And therefore when light comes in, instead of forming a nice smooth beam on the retina, the light is scattered and patients come in to complain about glare at night. Lots from headlights in particular is one of the biggest complaints at nighttime. This is one of the things that usually drive patients in for a cataract exam or for a dilated exam in general, and then we give them the diagnosis of having cataracts. So let's talk about risk factors again. Age, that's one of the big ones. Again, we do have congenital cataracts as well. And we do have some things that can cause a cataract to progress at a much faster pace and in a younger patient. But for the most part, this is a disease again, or a change, I would say, of an older population or geriatric population. Medical conditions such as diabetes that can cause cataracts to progress at a faster rate. Trauma can cause that lens to become opacified. UV light, medications, especially steroids and diuretics. Alcohol consumption, and not just your occasional glass of wine, but specifically if you're heavy alcoholic drinker, Smoking and exposure to toxic substances, these are all things that can cause the cataracts to progress at a faster rate, meaning not cause the cataract to happen, because we all will develop cataracts, right? That's just part of life. But some of these things can just help them progress faster. Treatment for cataracts in the early stages, we will just monitor the cataracts, okay? So when we first start to see the early signs, because again, it starts as just a little what we call yellowing of the lens. And as you go to your eye doctor and they keep monitoring it, they'll eventually tell you it's time for cataract surgery. So going back to the glaucoma discussion, I kind of mentioned that we do have some procedures, MIGS and the Omni, and these are procedures that can perform during cataract surgery, where we kind of treat two things. We'll treat the cataracts and also perform another procedure where we can go ahead and treat the glaucoma as well. So, and there's a bonus to cataract surgery. It's basically refractive surgery. So this is one of the major things I tell patients, or patients who know this will come in and say, I'm ready to have my cataracts removed, because they know during cataract surgery, we do measurements that will basically determine what your prescription is needed inside the lens. And during cataract surgery, we will insert an implant that will have a lot of your prescription implanted in that lens, which could possibly get you out of glasses or less dependent on glasses, okay? So that's what, so ultimately what patients almost always say after cataract surgery is, I should have had this done a long time ago. I don't know why I was so scared. The surgery is super fast. It's about 10 minutes per eye, very little downtime, very low chance of complications. So patients almost always say colors are brighter, contrast is improved, vision is improved. I don't have to wear glasses as much as I wore before. And I just wish I wasn't so scared and I did this a really long time ago. All right, so that ends my part of the presentation. Again, here's my contact information here. I work at Oklahoma Eye Institute. There's my telephone number and email address. We do ocular disease. So we don't, at our practice, we don't necessarily do any glasses and contacts exam. We do the eye health part. We dilate, I do a lot of management and treatment of ocular disease, glaucoma, macular degeneration, pre or post-op cataract surgery. We also do laser treatments as well. So if you have any questions or anything, don't hesitate to contact me. And I'll forward it over now to Dr. Bonner. Thank you.
Thank you, Dr. Griffin. Dr. Bonner, I think you might be muted.
There we go. There we go. Okay. Thanks, Dr. Griffin. That was amazing. I'm glad you jumped on, because I'm pediatrics, and that's what. Okay, awesome. So let me go ahead and share my screen and we'll get started. We're basically going to kind of be moving gears. I'm a pediatric specialist, and I deal, solely, mainly what I deal with is going to be the functionality of vision. So I won't touch on too much about when it comes to the health aspect of it, but just know, I think the biggest thing to know that everything that Dr. Griffin just went over, that can happen, at an early age, whether it is glaucoma. Sometimes there is the congenital cataract where you want to make sure they get in and earlier, sooner than later. So, but let's go ahead and get going. So, okay, so a little bit about me. I'm from Moore, Oklahoma, born and raised in South Oklahoma City. There, I went to University of Incarnate Word, Rosenberg School of Optometry. I'm actually had the privilege of being the first class through that school, which was very exciting, exciting and new. The only hindrance, right, you don't have the upperclassmen to chat with and get those notes from the previous lecture. So in optometry, more specifically, you could say I'm a neuro-optometrist, and I just think about it easily as a sense of, just how is the vision functioning? So whether it's developmental, when it's pediatrics, neuro-optometric, whether it's me dealing with concussions, any type of trauma or a stroke, 70% of our brain is dedicated to vision in some fashion. So any of those is definitely going to hinder the visual system. And then also sports or visual performance enhancement training. So not so much on the disease aspect of it, but on how is the eyes functioning. So the topics for me is going to be the importance of vision and learning. We'll talk about vision-related learning problems, and then just kind of a quick contrast of what's the difference between a comprehensive eye exam and a vision screening. So Dr. Griffin went in deep with the details, and that's amazing. So I won't have to talk too much on that there. So vision is more than just 20/20. It really has to do with, how is the vision functioning? You can have 20/20 eyesight and still, have a vision related learning problem. So when those kids do that vision screening and they can see, 20/20, and it's like your vision is solid, you should be able to learn and do what you need to do with your vision. But a lot of the times that's not the case. The system really has to do with, how are we interpreting and responding to the world. A number that is very daunting to me is just that 80% of what we learn is processed through our vision, and not only just what we learn, but what we do. When you're driving, when you're walking, when you're riding a bike, all of that information a lot of that information is being processed through our visual system. And it's easy to just kind of think of that as a number, but when you sit back and think about it, that's a large number. And especially what we're at this day and age, how we're asking our kids to use their vision with the digital devices and things of that nature. How important is vision? We learn what clear vision is. It's a process. We just don't come out the womb and 6 months, we have 20/20 vision. It happens over time. In order to do that, you have to have clear vision. We learn what that is, but it has to be there for that to be processed and done. So the ability for to perform any tasks, our self-esteem, how we interact with others, a lot of that is affected by our vision. Vision guides who we are, where we are, where something is. And when I say it guides who we are, just something as simple as, you have that 4 or 5-year-old that, it's a boy, right? They're super excited. They got all this energy, and you give them the look, right? It's like you're not doing what you're supposed to do. And they don't respond to it is because they probably can't see, that facial expression for them to stop that interaction. So they just keep doing what they're doing. So it goes more than just, how can I see things clearly, but it really guides and leads, a person and what they're doing. Any type of visual deficit, it's going to affect we're going to have bad gross motor or fine motor coordination, walking around, grabbing, a pencil or writing, handwriting, doing a simple arts, craft or something, having that fine motor coordination. It really has to do with our vision, because if it's blurry, inconsistent, or it seems like it's moving, we're not going to be pretty accurate with our eye-hand reactions and things of that nature. And then also, untreated vision problems, they have a profound effect on, our posture, our balance, our behavior, learning, and also sports. Some kids go from T-ball to coach pitch, and they have this drastic drop down, and they're wondering why, even though they're putting in the time to do it there. So vision and learning, my favorite subject. So children with vision problems, they can easily be misdiagnosed with ADD, ADHD, some type of attention or hyperactive disorder, just because they, skip a few or reread lines, they have poor reading comprehension, and then they take longer to do homework. It's common for me to hear the parents that come in, and they get exhausted because they know when it's time to do homework, it's going to be a fight. The kid is going to struggle. They're going to cry. It's going to be, frustrating for not only the kid that's doing it, but the parents, because they're trying to keep them on task. And they just don't realize it's more than likely going to be, a lot of times it's a vision problem and issue. And then displaying that short attention span for near visual tasks. So when they're sitting at school and, things are straining, I can't see, it's blurry, I'm getting this headache, I'm definitely going to stop doing what I'm doing up close, because that's, a lot of the times causing that strain there. There's over 15 visual skills that are required to, read and learn accurately. There's actually 17, and I'll show you here in a second. But recommended ages for eye exams. This is huge. A lot of parents come in and, 4 or 5, And they're like, I didn't know that I could have them come in at age 3, or 6 years. So, the recommended is 6 months. At that age, we can't, of course, say, what, read me those letters, read me those pictures. But we can get an idea of what's going on with their visual system. And we're looking for the huge stuff. We're looking for the ocular health. We're making sure that there's, white pupil, meaning a tumor in the back of the eye. But visually, we're also looking for making sure that the prescription is pretty symmetrical. There's no eye turn that the parents are noticing that's consistent. But we definitely want to make sure, again, we learn what that clear vision is. So we have to make sure that the vision is able to learn that. And that's going to happen with glasses and prescription. So little ones will come in with the prescription and that's normal. We'll just kind of watch it because our eyes actually naturally try to get to the least prescription as possible. But at some point, it go ahead and plateaus, and that's when we need to jump into those glasses there. And that's about 3 years of age. We start to get that adult-like vision. So at that time, I can know if somebody's still struggling with their vision. A lot of the times we need to get you in some glasses and get you going, whether it's just schools and screens or you jumping in them full time. We need to get you in something. And then at 6 years, we're in kindergarten, we're about first grade. That's when we're really starting to learn and put those words together. If it's not clear, if it seems like the words are moving, we're going to have a hard time learning to read. And that's, the next statement there is, a child must have the visual ability to learn to read before they can read to learn. So, and that's huge. Somebody who's fighting their vision just to get words and put them together, they're never going to enjoy, the joys of getting lost in the book because they're fighting their vision just to get from one word to the next or sentence or next paragraph. So, vision related learning problems. So just some vision symptoms. They're going to have jerky eye movements. You'll see an eye turn in or out. They're squinting a lot when they try to see, eye rubbing, excessive blinking. You'll see blurred or double vision. And the double vision, it doesn't have to be two separate images. It can be as simple as the words just slightly separating and overlapping, and it's causing distortion. Headaches, that's probably one of the biggest things that I've noticed that kind of goes to the wayside, saying that, they're probably dehydrated or I thought they were just hungry. But a lot of these kids, barring no medical concerns, a lot of them, if they're getting that headache at school consistently, more than likely it's going to be a vision problem because when you're at school, everything is so visually demanding. That's the body's feedback is like, I'm gonna give you a headache, so you'll rest. I need rest because it's tough doing this visual stuff. And they'll be dizzy, nausea, after reading, and then if we have one eye that's just not working well, they'll tilt that head, they'll close one eye or block one eye, when they go to read, and that's real comfortable for them. If you notice any of those, that's definitely a vision issue. They're having trouble, those eyes working together. Some things that, emotionally, low self-esteem because at some point they're told that they should see this, they should know this, but if visually they can't see it or it's very uncomfortable, they're going to start to kind of guess themselves, and it happens all the time. I have to slow the little ones down and say, wait a second, I know you can see it now, let me know what those letters are versus, can you read those? And they give me a head nod and they just start reading, random numbers. It's like, whoa, hold on. So they get used to guessing, they have that poor self-image and they get frustrated, they're stressed, a lot of times with that homework, frequent crying, like they break down because it's like, here we go again. I'm exhausted. I don't like this stuff, and they get irritated very easily because it's a daunting task, especially nowadays. We've gone from when I was growing up to, simple cutting out shapes and coloring to these kids need to be fluent in reading, very early. And it's a stressful environment for them. Performance indication. So they're going to avoid near work, poor reading comprehension. They're going to lose their place a lot. They're going to add in words, switch them around, move them. They're going to confuse similar words like was, was, saw, on was no, things like that. And then, they just said one word and they're halfway down the paragraph and they messed that word up again. Well, when they first started reading, it was either blurry or clear. And then by the time they got to the next, that same word down the page, it's blurry and inconsistent. So they're just kind of guessing and throwing words together. Difficulty, copying from the board, chalkboard, whiteboard. Whenever we look up close, our focusing system has to go to work. That's muscles in our eyes, making that clear image. Well, if they're always working and they go to look up, it should relax. They're in a spasm. It's going to be hard to look up and clear that image. It takes a while. So they might get behind when somebody next to them is, getting through the notes pretty well. So that'll be frustrating as well. And again, with sports, they'll be inconsistent. And then the social labels, being labeled lazy, you don't want to learn, why don't you want to learn this? Dyslexic, why do you keep switching these words around? Attention deficit, we mentioned earlier, slur learning or behavioral problems. You can, with dyslexic, of course it's, they're going to switch those words around because one moment it's clear and the next moment it's blurry and they're guessing, and our brain just puts words together so we can get through things. And then here's that, 17 visual skills needed to succeed when you read. It's huge, how are those eyes moving? Where are they pointing? And when I look at a book, my eyes align on the book, in front of it or behind it. Our side vision, which helps us to get from one word to the next. Depth perception, gross motor, fine motor, and there's a huge long list. And I got it off of covd.org. It's an organization that's dedicated to visual development and vision therapy and all of that. So let's see. So this is a simple, example of whenever they're reading and those eyes aren't working together. This is kind of what these kids are seeing every once in a while, or maybe all the time. And it's huge for them to try to read because they're told that they should be able to read this when, they don't know that this isn't normal and they're fighting to get through that there. Let's see. So, some statistics. Just want to highlight again, 80% of sensory information is from our visual system. That is huge. We can't ask a kid to learn something if they can't see it. That's just tough. And then the ones on the bottom, 50% of vision screenings, they miss vision problems. A lot of the times, the ones that pass that vision screening, they're going to be the ones that actually going to have the vision problems. If you're nearsighted, you're going to fail it, and you're actually going to get taken to the doctor and get your glasses, and you're good. And they're actually the ones that are actually doing just fine. And then let's see, 60% of students identified as problem learners. They just have undetected vision problems because they can't see the information to learn it. And then I wanted to throw in here vision and juvenile delinquency. When I came across this a while back, it was just kind of eye-opening, and it's exhausting. But 75 to 90% of juvenile offenders, they have undiagnosed vision problems. That's the time, at that age when they should be learning. Well, they don't want to learn because they can't visually. Things are just too tough for them. So that just really stood out to me and just kind of, in a sense, broke my heart that, somebody who just has a vision problem, ended up in, as a, a problem child, I guess you would say, or ended up in the system, and they shouldn't have, just by having the right eye care. And then a quick thing. So with vision screening test. So, and I point this out not to take away from the efforts that the individuals that do the screening, but just for the parents, for the ones that come back and they say, Johnny had a screening, an eye test at school, his vision was fine, we don't need to go see an eye care professional. And that's the disconnect, is even though they may pass the vision screening, their criteria on there is just not as as tight as when you come in to see an eye care professional. We're looking for the standards, and there's stuff that stands out that a layman probably won't notice. So your basic vision screening is just going to be the eye chart. Can you see that 20/20 line on the distance? And again, like I started off with, vision is so much more than just how clear the image is. It's how those eyes are working together as a team. And then I would say advanced they'll go and check your color vision, depth perception. And nowadays technology is great. So, they have these handheld devices where you can kind of estimate the person's prescription. But a lot of times that's just a starting point. And it doesn't, tell the whole story. And whenever they're doing these testing, only the noticeable concerns actually get referred out. So just because you're not 2 times less than normal, and that's where they decide to refer you over to an eye care specialist, 2030 might be the benchmark that's really having you struggling at school, or you're in the back part of the room and you're 2030 and you're squinting all the time, and that's what's causing your headache. So, and then, Dr. Griffin went over, a comprehensive eye exam. But here's, just kind of the basics of it. So you're going to check your clarity, we're going to see how your eyes are moving. We'll check your color vision. How is your eyes aligned? Does one eye point out, in? When I look at the book again, am I pointing, are my eyes at the book? Is it behind it? Does one eye want to turn off? That's going to be huge, especially if we have to read this book for 20 or 30 minutes. The brain's going to get exhausted trying to put those images together, or use the power to suppress and turn off one eye so the other eye can just kind of do all the work. Accommodation, that's just a fancy word for, me making an image clear for you. And then vergence, that's just my eyes pointing to my nose. If I can't, bring my eyes in together closer than 40 centimeters, kind of where I'm reading, that's when the visual stress comes, that depth perception. And then we'll get that final glasses prescription, whether it's small or a lot. We can kind of let you know when you need those. And then, of course, the ocular health assessment and those congenital conditions, anything that a lot of the times that the adults can have, the little ones can have as well. And it's very important to come in and make sure that we don't have anything that stands out. And then on the note of the headaches, sometimes a headache may not be visually related. It might be, an increase in, the pressure inside the head. So, causing, some optic nerve, swelling and things of that nature. And we can see that whenever you come in. So, not all headaches are related to vision. Sometimes it's actually, a health emergency and we need to get you in to see somebody. So let's see. Yeah. So I'm gonna play this video. I love this video. It's a quick shot. These doctors did an amazing job of doing this.
Less than 15% of kids have actually had their eyes examined before starting school. It's shocking because 80% of learning is visual, it's through our eyes. So these kids are struggling with misdiagnosed as having behavioral problems, attention problems, when a big component to what's holding them back is a vision-related learning difficulty. So today, we're doing some vision experiments with 4 healthy adult teachers. We want to put them through common conditions that are going to impact their ability to perform normal, everyday vision tasks.
Essentially what we're doing is we're doing a little visual experiment. And the reason that it's important to have you guys here as teachers is because you're working with kids every single day. Vision and learning is huge. 80% of our learning comes from our eyes. So we're trying to demonstrate that there are very, very common visual conditions that go undiagnosed and that kids live with in your classrooms every single day, and you may not even know it. Every parent needs to know that this is possible. It's not always obvious. In fact, in many cases, it's not obvious. The best way to show somebody how a child sees is to have them see that same way. So what we're going to do today is demonstrate what non-obvious problems can look like. We're actually going to test your distance vision and your near vision.
Similar to what a child might experience in a school screening program. We had 4 volunteers, and each of them we put through a different vision experiment. Riley is nearsighted, so we didn't do anything to her eyes except not let her wear her glasses. Desiree was experiencing convergence insufficiency. We put prism in front of her eyes to force the eyes to not work as a team, to not be able to look at the page, creating double vision for her. Michelle was experiencing amblyopia. We put a contact lens in her right eye. This contact lens blurred the vision to the point where she wasn't able to use her eyes as a team, and one eye had to do all the work. And our last volunteer was Tanya. Tanya had contact lenses in both eyes, and these contact lenses mimic astigmatism. So she saw distortion near and far and had a lot of difficulties keeping attention and concentration on anything she was doing. Okay, can you read the lowest line you can with your eye cup?
LEPD?
Is that the lowest line you can see?
Yes.
Ideally, the 20/20 line is the one above the red. So Riley has difficulty. She's having trouble seeing in the distance. So Riley's an example of a child that may have trouble seeing the blackboard. So a screening is going to pick this up. Can you try reading? We'll start with this line. Can you read this one?
Yes. B, D, F, C, D, E, F, B, F, C, E, P.
As quickly as you can, I want you to read the numbers out loud, top to bottom.
Okay. 9, 2, 3, 6, 4.
3, 7, 5, 7, 4, 6, 5, 2. It's almost like instead of like flat, it becomes three-dimensional.
So some of it pops, some of it.
Yeah.
Do you remember a lot of what you just read?
Well, but not really.
The whales appeared, and then I can't see what it says underneath the back line. Holes and filled their huge lungs. The Inuit gave something names.
Are both your eyes open right now?
I'd have to blink back and forth to see the different lines.
You couldn't use both eyes as a team.
No. I can see how the one eye, you would slowly start to disengage your brain because you want the good eye to take over.
Mm-hmm. Tanya, you seem a little tired.
I'm getting annoyed. I just felt like I didn't get a break. Everywhere I looked, things were distorted. So my eyes couldn't rest for a minute unless I closed them or looked at like a flat surface. Like even faces. I'm trying to listen to what you were saying, Chris, and I wasn't there anymore because
So you could have been looking right at me.
I was.
But you weren't.
No.
Riley was probably one of the most common reasons someone goes to see their eye doctor. It's because they come in and they say, I can't see the blackboard anymore. Or they're squinting to see the TV. So it's very obvious to the parents and everyone.
So there would be some sort of intervention here that would happen with Riley in a regular class because she failed that screening test. Yet she outperformed all you guys.
It's easier to just go to something that doesn't require so much concentration or it doesn't rely on your eyes so much.
It can really affect your esteem, your self-esteem, your ability to want to read, your wanting to go to school. You wouldn't want to go to school. You'd rather be out playing on the playground where you don't have to use your eyes under this kind of strain and stress. As much as these are tests, they're mimicking the things that would happen in a classroom on a regular basis and things we're going to ask our students to do to learn.
Absolutely. I'd talk to the person next to me or do something else, engage in something different where I could get my confidence back, right? Mm-hmm. Something where I'm like, oh, okay, I can do this just like everybody else, but then no one has to know about my eye problem. So I'm just going to be the kid who, or be the student who just kind of rebels because it gives me more confidence to do that.
You use that word rebel probably because it's an instinct. Did you change what you refer to that as now, knowing that they're not actually choosing to do something different? It's almost as if they can't do what was presented before.
Maybe there's something bigger here that I'm not seeing, and that has to be tended to first.
In the primary grades, you learn to read, and then in the junior intermediate, you read to learn, right?
Yeah.
So I'm thinking about these kids who will always be having to focus so much on the word that, are they getting the content areas? Are they understanding as much as they could be? Because it's still a lot of work for them just to look at the page.
You can't do the basics of just looking at the page and reading. You're never going to enjoy reading, ever. And you'll never know why. You'll just label yourself as someone who doesn't like reading.
2020 is important, but there's so many other things that we've interfered with in terms of your skills, your ability to get information, your ability to process that information.
2020 gets you to pass that screening test, but it gets you to fail almost every other real life test, which you guys just went through today. We need kids to have their eyes examined by optometrists to look for things that a vision test, a vision screening isn't going to pick up.
Awesome. Yeah. So I love that video because it just kind of tells the story so well, and the way they did the little simulation with the teachers was absolutely amazing. So, but yeah, that's all I got. Just wanted to kind of go over the visual aspect of it, of kids and learning and how important vision is, and just because Johnny's not paying attention, it may not be because they don't want to. It's maybe because they can't.
Yeah, well, Dr. Bonner, Dr. Griffin, thank you both so much. Such valuable information, even sitting here, even as we've, done some screenings, I've always been one that thought, maybe similarly to a lot of the folks, in the video you showed, and maybe with some of the examples you both shared, that, at the end of the day, it's really important just to respond to your body, to listen, and to make sure you get, proper care. And so with that, we had a question come through. And then while I put this one to you guys, if anybody else has questions, feel free to chime in and ask them, or feel free to put them in the chat. But a question that somebody put in is, what is the treatment for dry eyes?
So honestly, when it comes to dry eye, I really thought about adding this to my presentation because it's probably one of the most common things that we treat. Everybody has dry eyes, especially here in Oklahoma, we see a lot of dry eye cases. So there's really not one answer for how you treat dry eyes. It depends on the cause of the dry eyes. So one thing I'll hear patients say all the time when we tell them they have dry eyes, because we do dry eye testing on all our patients who come in. We do a dry eye questionnaire, and then we do 2 tests. One test for inflammation. Is there any inflammation in the tear film? And is there any, and the next one tests the osmolarity. How salty is the tear film? So, and a lot of patients, some will say, I don't have dry eyes. As a matter of fact, my eyes tear a lot. I'm constantly tearing, so I don't have dry eyes. And that's actually the opposite. If your eyes are constantly watering or tearing for no reason, that's actually a sign that you have really dry eyes, and your body's trying to overcompensate for that dryness by producing more tears, okay? And that tear is actually not a good tear. That tear is very salty, and it's actually pulling away more hydration away from the eye and causing more dryness. So, so just keep that in mind. If you have tearing for no reason or watering for no reason, you have dry eyes. If you're using something right now like Visine or Clear Eyes, trash it, get rid of it. It's no good. Ones that I would recommend: Refresh, Sustain. These are over-the-counter drops. Refresh, Sustain, Blink Tears, Terra Tears. Those are really good and more reliable eye drops for the eyes. If it's if it comes in a bottle and it's preserved, it has preservatives in it, no more than 4 times a day. If you feel like you need it more than 4 times a day, you need to switch to the preservative-free form of the drop. Yes, somebody said, yes, Refresh, switch to preservative-free form. Oh, you're typing it in. And you can use it as many times as you want. But if you feel like you're using it that many times, then you probably need to come in so we could do a dry eye evaluation and determine if we need to prescribe something for you like Restasis or Xiidra. These are prescription strength drops that actually help the body do what it's supposed to do. Other things that we can do in office, sometimes we put punctal plugs in. So we have a drainage system on your top and bottom lid that's constantly draining fluid from the eye. So we can plug the lower lid, we can plug the opening that's in the lower lid. And again, this is super easy. It's not hard. There's no pain or anything associated with this procedure. And that actually helps the treatment as you use the eye drops. Instead of that drainage, those little openings just draining away the artificial tears that you're using, it helps the tears to stay on the eyes a little bit longer. But the key to treating dry eye ultimately is determining the ultimate cause of the dry eye. Meaning some patients are taking medications that dry the eyes out. For instance, antihistamines, those dry the eye out a lot, anti-seizure medications and so forth. They add to dryness. There's certain things such as Sjogren's disease. If you have dry mouth and dry eyes, we may consider getting you tested for Sjogren's disease, and then we'll also set up treatment with a rheumatologist at that point. But if it's something systemic or Medicaid, that would be the key thing to let's try treat the systemic problem. The next thing would be you have 3 layers of your tear film: mucin, aqueous, and lipid. We have to determine which layer of the tear film is being affected and causing you dry eyes, because if it's aqueous deficient dry eyes, then that's a different treatment from if it's lipid deficient dry eyes. Lipid deficient dry eyes can be a patient who's just not blinking completely, because that's where the lipid layer is produced from your tear film. Every time you blink, you produce a lipid layer onto your tear film that then coats the inner aqueous layer, okay? So I know it sounds simple, but sometimes I just tell patients blink. Just remember to blink, and not just blink like this, because we will record patients who would do what we call incomplete blinks. But we mean full blinks, actually have the lids touch, and that will produce the oil from those oil glands, okay? So that's one of the key things. I also tell patients a 20-20-20 rule. If you're doing long tasks, we're on our laptops and cell phones a lot more. We forget to blink as often or give our eyes breaks. So after 20 minutes of reading, take a 20-second break, look at something 20 feet away, And I tell them to also blink at that time. Make sure you get actual blink to produce that lipid layer onto your tear film. And I could go on and on, trust me, about dry eyes. I do this so many times and I have this conversation a lot. But so one of the things we can do actually is do a scan of the glands in your lid, because sometimes a patient is blinking, but it's just not, the glands itself have atrophied and died, which means you're not producing any oil. And then we have to add something like, so when you go to the store, you'll see like refresh, cysteine balance, refresh optique, advanced, and regular refresh. So the difference between the two, one is an emulsifier that walks on, it's basically a replacement for that lipid layer, whereas the other one is a replacement for the aqueous layer. So again, we have to kind of determine which layer of the tear film is being affected in order to treat your dry eye effectively. Heat therapy is also a really good one. By heat therapy helps to loosen up the oil in those oil glands. By heat therapy, not a washcloth, it just doesn't heat the glands long enough. You want to use something like an actual heat mask, or if you have some rice at home and a clean sock, rice in a clean sock, microwave it for a few seconds, that will actually hold the heat long enough to keep on those oil glands. And then the next thing will be incorporating fish oil into your diet, taking a fish oil orally. It has good anti-inflammatory factors in it, and it also helps with the integrity of that oil that's released from the oil gland. So try those, and if it doesn't help, again, it's all about pinpointing the specific type of dry eye and kind of tailoring the treatment based on that. I hope that helps.
Dr. Griffin, you've got me thinking about whether or not I don't blink all the way. Am I completing my blinks? Another question that I want to pose, just to kind of look at the pediatric side, is if I have a child and I'm not sure if they have a vision issue, what is the biggest recommendation or something that you would recommend to parents as a good first stop when we're talking about vision care for our children?
I think the most important thing is just having that comprehensive eye exam. That's what's going to lead us down the way and let us know if and when we need to give glasses. But also being observant of the child. And that's kind of, it's like, I notice my child all the time. But a lot of the times I'll ask the parents, do you notice them blinking a lot or rubbing? And, a lot of the times it's like, no, I don't think so. And then on the next exam, they'll tell me, yeah, I did notice, they were blinking a lot, they were rubbing their eyes a lot. And a lot of that has to do with, they're actually, if a kid's eyes are drying out and they're not on medication and they don't have any type of health concerns or anything like that, usually they'll need glasses because they're not blinking at all. Their eyes are just staring open, and because every time we have to blink, they have to refocus the image. And after a while, that becomes a very daunting task. So it's just kind of, but the big thing is I think just going to the eye care professional. We, again, at the location I'm at Venture Vision, we see them as young as 6 months and on up, but making sure we don't rely on the school screening. Kid comes home, Mom, I passed the vision screening. And then the misconception is, okay, my child's eyes are fine. We don't need to go see the eye care professional, but that's, farther from the truth there. So I think those are the big things.
Well, Dr. Griffin, Dr. Bonner, once again, thank you both so much. It really was a pleasure to hear from you. I get to learn so much as we have these calls and opportunities. And so I just want to thank you both. I'd love to, get any information that you guys have about your organizations out. And so I'd love to contact and get in chats with you about getting that information out. Otherwise, thank you guys for being on and listening and learning with us. Thank you guys so much, and I really hope that you guys stay well and continue to be such a positive force in the communities you're working in.
Awesome.
Thank you.
Thank you so much for having us. It was a blast. I really enjoyed doing this.
Yeah.
For sure. Well, you guys take care. We'll see you sometime soon.
All right, y'all have a good one. Thanks for joining us.